Hello and welcome to the special webinar on organ donation and infection control disease during the COVID pandemic. I am Luciano Potena from Bologna and I'm ESOT President-elect, and I'm very pleased and honored to chair this session which will be participating with Chad Ezzell from LiveOnNY, Christian Benden from Swisstransplant in Bern, Timothy Pruett from the University of Minnesota, and Jonathan Hand from Ochsner Clinic in New Orleans. This webinar is a multi-society webinar and is co-sponsored by AOPO, AST, ASTS, HSLT, ESOT, NAPCO, TTS, UNOS, and CST. I'm now pleased to introduce the first speaker, Chad Ezzell from LiveOnNY. Please, Chad, go on with your talk.
Thank you, Doctor. Good afternoon. As everyone is aware, New York City is one of the current hotspots for the coronavirus pandemic. This situation within the OPO and hospitals changes daily, if not hourly. As of April 15th, there have been more than 200,000 confirmed cases of COVID within New York State and nearly 11,000 deaths. We receive reports daily from our mayor and our governor on the current situation within New York State and New York City. So facilitating the organ donation recovery process in the current environment has been extremely challenging. One of the specific areas that we have had to increase focus upon is providing the appropriate precautions for the procurement teams. Next slide, please. So before getting into the specifics of the procurement process, I'd like to review some of the changes that LiveOnNY New York have put into place for the donation process as a whole. So you see on this slide, I've broken the donation process into 5 major stages. First, referral. We have seen an over a 300% increase in referrals coming into our donor center. However, the number of vented referrals has significantly decreased, limiting the number of donation opportunities. With the pandemic, we have had to adjust our approach to which donors we are pursuing, such as DCDs. Pre-pandemic, if a family was interested in donation, but the likelihood of a timely expiration was low, we would still make the attempt. Now we don't, as it is not the most appropriate use of hospital resources. We're also limiting the evaluation of potential donors that are over the age 80. Another area that we've adjusted in is our on-site response. We have modified our on-site response algorithm for our transplant coordinators. Rather than sending staff for all vented referrals not meeting an initial rule-out criteria, we have had to transition to performing remote evaluation unless there's brain death testing being conducted, or a patient is reported areflexic, or if we have a family on site that wants to discuss their donation opportunity. Family and support and authorization process is another area that we've had to adjust. The restrictions to visitors in our hospitals, our family care coordinators have had to transition to having many of the support and family care discussions and authorization conversations over the phone. We've utilized technologies such as FaceTime to facilitate these donation discussions. We've also utilized FaceTime for virtual presence of families in the OR during a DCD withdrawal so that they could be present and be there with their family member in the OR during the withdrawal process. And for donor management, we require that there be a negative COVID test on that current admission prior to LiveOnNY New York performing any hands-on assessments of the donor, such as a physical assessment or confirming height and weight or any type of donor management. And this is just to minimize the potential for exposure of our staff to COVID. Upon gaining authorization, we immediately get a lung consultation to assist us with donor management. And also upon authorization, we attempt to move the donor to a non-COVID unit to decrease the potential for exposure during the donation process. Hospital resources have been extremely taxed during this time. We've had several donors that we've transitioned to stretchers, moved them to transport beds, and moved patients out of the ICU into, say, a PACU unit so that we can free up that precious ICU bed and scarce ventilators for other patients. We understand that the healthcare workers have been overburdened, and this has led to significant delays in us obtaining CT scans and cardiac caths for donors. So right now, when we have a donor, we are really evaluating what diagnostic tests we want to complete so that we can facilitate the donation process. We certainly don't want to use more resources than we need to. As for the procurement and allocation, there's three main areas we have had to adjust in regards to procurement and allocation, and those are the interactions with our donor hospitals, transportation, and recovery practices. I'll talk a little bit more about that in depth. Next slide, please. With the significant increase in COVID admissions, the hospitals have developed protocols for restricting access to our hospitals, such as limiting the entry points to the hospitals, completing a health screening, such as taking a temperature of anyone entering the facility, people requiring masks to be worn upon entry, and also limiting access to only healthcare staff. Another area is access to hospital PPE is being tightly restricted due to its limited supplies, and this includes the OR as well. We at the OPO at LiveOnNY New York have been providing our staff with their own PPE to bring with them to the hospital so that we're not utilizing the hospital's limited PPE resources. And understandably, everyone knows that COVID testing has certainly been a challenge. As I've said previously, we require a negative COVID test prior to our staff interacting with the donor. We're trying to really reduce that time from the COVID test is completed to the time of recovery to be less than 24 hours to reduce that window of possible exposure of COVID during the donation process. We're working closely with our local hospital partners that have availability to complete the COVID testing with a turnaround time of less than 12 hours. So if we evaluate a donor that needs to be retested, if the timing of the first COVID test is greater than 24 hours, we'll evaluate to see if we want to retest that donor to narrow that window. Next slide, please. The transportation systems we had in place basically collapsed. The local courier companies we use for transporting specimens such as serology and HLA to our labs and organs to our transplant centers experienced significant shortages in staff, which facilitated great delays in service. So to remedy that, we began utilizing our on-call staff and non-clinical staff to transport these specimens and organs to our facilities. Also, many of the flights out of New York City were canceled, causing delays in ORs and also extended cold times to the organs that were being allocated outside of our DSA. We've even had the experience of a concern of one transplant center that their charter plane company had concerns about flying into New York City and put restrictions onto it. Next slide, please. Changes focusing on recovery. We obviously had to modify our DCD process. We really scaled back on these cases, which demonstrated minimal potential for timely expiration. We've also have a hold on all of our research projects, such as DCD heart program and ex vivo lung programs. We are really trying to utilize our local recovery surgeons to help decrease exposure of teams from outside the DSA and also minimize transportation challenges and decrease case times by eliminating travel from outside teams to get into New York. We've collaborated with our local surgeons to get their availability and to be able to recover for these centers outside of our DSA. In regards to allocation, excuse me, we've really moved to expedited placement much more early in the process. Myself and the Chief Medical Officer, Dr. Amy Friedman, are calling our transplant programs and surgeons directly to discuss specific donors and any organ offer to enhance the likelihood of placement. We've also had to work with our vendors to increase the level of PPE levels and also recovery supplies, with the anticipation of any sort of citywide lockdown that would interrupt the delivery of any of these precious supplies, so that we could continue facilitating the recovery of organs. Each morning, we've conducted a call with our staff and discussing their health and availability for procurement. Any staff member that comes up symptomatic, they are immediately removed from our call schedule and they are put in quarantine until cleared. So these are really the things that we've put in place at LiveOn New York for putting in place for precautions for our procurement teams. And that's all I have.
Thank you very much, Ezzell, Chad. And we can move to the next speaker, Christian Benden from Switzerland, and he will talk us about the screening for donors and candidates.
Thank you. First of all, I'd like to thank Professor Bloomberg and the organizing committee for inviting me to speak, and also Dr. Potena for the kind invitation. I'm a consultant at Swisstransplant, which is the Swiss National Foundation for Organ Donation and Transplantation. What I thought is important on the first slide you see here now is that we are now talking about a difficult issue, because we want to obviously continue transplantation, but we are all fully aware of the difficulties for our healthcare system to provide appropriate care for all the COVID patients, in particular those requiring intensive care unit admissions. And there's a very good article that's been published about a decade ago looking at principles for allocation of scarce medical interventions. And I just want to point out that in pandemic situations, allocation of scarce intervention to people is absolutely instrumental, and that a framework is really required, expressing widely affirmed values. That means priority to the worst of, maximizing benefits, and treating people equally. And this is really important to have a dialogue regarding ongoing transplantation during the pandemic. In Switzerland, even though it's a small country with only 8.5 million population, we had various regions and cantons differently affected. In particular, worse those neighboring Italy and France. And so we had to look at Swisstransplant on a daily basis with the procurement areas and also the transplant centers, where operations are still in place, and what are the capacities of the transplant centers to still carry out vital organ transplantation. Meaning that very early in the pandemic, a living donor transplantation in Switzerland, for example, was paused, as was kidney and pancreas transplantation, and only transplantation of vital organs continued. And this is an ongoing process. We're now slowly reopening centers for kidney transplantation as the pandemic is slowing down in Switzerland. On the next slide, I look at the screening of donors. So as far as I know, transmission of SARS-CoV-2 from donor to recipient had not yet been reported, but obviously we have to balance the risk of a viral transmission against the risk of not using an organ, always bearing in mind that patients are dying on our transplant wait lists. So donors with a history suggestive of SARS-CoV-2 infection are to be avoided, and all donors to be tested for SARS-CoV-2 infection were available. And I recently learned that this is very difficult in some areas. Even in the United States, I've been told that some centers require a couple of days for tests to be conducted and results to be returned. That's obviously an issue if you talk about the procurement process. So their potential testing tools are nasopharyngeal swabs, tracheal aspiration, and bronchoalveolar lavage, the latter being obviously the one with the less false negative results. CT chest imaging is recommended also to exclude viral pneumonitis where available. And just recently, there was a case published in the Journal of Heart-Lung Transplantation where during organ donation workup on CT chest imaging, changes were diagnosed compatible with COVID-19, and those have prompted for bronchoalveolar lavage to be performed and executed, and then a SARS-CoV-2 infection was confirmed, and obviously the process of organ donation was then stopped. On the next slide, I look at the candidates. So the routine pre-transplant checks are obviously recommended, and we would want to exclude waitlist patients from immediate transplantation if there's a new onset of clinical symptoms that would be compatible with COVID-19. We would also want to exclude those with contact with confirmed COVID cases within the last 2 weeks, and also travel risk areas within the last 2 weeks if residing in an area without community transmission. So tests for SARS-CoV-2 are recommended, again, also for those candidates, and one can use as tools nasopharyngeal or oropharyngeal swab, sputum, and tracheal aspirates. And candidates tested positive for SARS-CoV-2 should not undergo transplantation. So the question is this very common? We're screening this very closely within Switzerland. As I said before, Switzerland is a small country with a population of 8.5 million. We have about 1,400 patients on the national waiting list, and less than 2% have been reported to us as being tested positive for SARS-CoV-2. And that's all from me.
Thank you very much, Christian. Now we can move on to the next presentation. And it's Dr. Timothy Pruett from the University of Minnesota, who will talk us about protecting the workforce, surgical aspects. Please, Dr. Pruett.
Yes, thank you very much. It's a pleasure to reflect on this. It's not something that has a great deal of data, but something which we need to address. The problem, of course, is that healthcare providers, and particularly surgical folks, have been a significant percentage of the COVID-19 infected population. As a consequence of this, the government has come up with a system response, which was to deny elective procedures. We found in this country, and I presume elsewhere around the world, that personal protective equipment is highly variable in its availability, and it's restricted a lot of folks, or let's not restricted, but it's exposed a lot of people to more problems. Emergent and urgent procedures, however, are expected to proceed, and transplantation, at least in the US, has been recognized by the government as being not elective and should proceed as medically indicated. And that includes all forms of transplants, kidneys included. COVID-19 is, of course, a respiratory disease, and the predominant way to prevent infection is through barrier protection to respiratory droplets and aerosolized particles. However, it's also been found to be in the GI tract, and the main prevention methodology has been distancing from the source and barriers between the virus and the healthcare worker's airway. However, distancing is really hard to do while providing hands-on surgical procedures or caring for patients with drains and open wounds. The American College of Surgeons and the Society of Gastrointestinal and Endoscopic Surgeons have on their webpage put out two different kind of recommendations. One is to minimize the number of people in the OR, avoid laparoscopy if possible because of the aerosolization which can occur with procedures, use smoke evacuators with electrocautery, all of which were concerned about the aerosolization. This has been a problem with other sorts of viruses, and particularly papillomaviruses with certain kind of laser surgeries. And so it's been an extension, but not a proven component. With aerosol generating procedures, especially those with intubation and extubations, the surgeons should stay out of the operating room until anesthesia induction is completed and to get out of there when extubation occurs as well. For anybody with suspected COVID, but it makes a lot of sense to do with all patients. Any open airway is a risk, and so the procedures associated with opening of the airway, either tracheostomy or potentially with donation-related procedures of opening the airway for lung retrievals, the notion is how to protect the surgical staff. The personal protective equipment for either an unknown or a patient with COVID-19 is full barrier. It's the whole 9 yards. It's the N95 mask, it's droplet protection gown, it's face shields, and if conceivable, even the entire hood. Whether or not one needs to fully engage in body fluids precautions, such as with Ebola virus, has not been clearly done. The current recommendations for operating on people with COVID, not necessarily transplant-related procedures, is just as I described, and not necessarily all the other precautions associated with that. For people who test negative for COVID-19, the current recommendation, at least by the American College of Surgeons and SAGES, is for routine surgical barriers. Could I have the next slide, please? So the transplant-specific issues are real. We know that transplant surgeons have become infected with COVID-19. Now, whether that's hospital-acquired, procedure-acquired, or community-acquired is not really clear, but without, when you're infected, it's hard to provide care. So the basic premise is in your different environments, stay safe. Do the social distancing in the community and in the hospital. Pay attention to the general rules which are there. For the specific things that we do in transplant, organ retrieval, live donation should be done only with caution. We're very concerned about the live donors, that they will get it in the sense of being in a hospital in a high risk area. Until after the surge, we clearly recommend doing it. It doesn't have much to do with the surgeon, but it's a question of where we go. We highly encourage both, as was said, donor and recipient for viral shedding, even trying to find the asymptomatic ones. And we think anybody with asymptomatic disease should be deferred, as we don't know what happens if it's either early in the course of disease or whether we can exacerbate it with immunosuppression and surgical procedures. Deceased donation, our main concern for the surgical staff is not to be a vector in and out of our own centers, limit travel. When you go into another facility, change your surgical garb in and out, wash repetitively, avoid retrieving. Don't retrieve organs from COVID-19 patients, as it almost guarantees that you will become some sort of a vector, at least out of the hospital. The transplant operation, again, we believe that avoiding COVID-19 patients, if feasible, is prudent, recognizing that despite testing everyone prior to transplantation, there's a significant false negative rate. And I think depending on the community which you're in with the prevalence of disease, you may want to think the listing and acceptance of organs for criteria for risk for the recipient. The risk-benefit ratio is real. The risk to the surgeon and to the anesthesia team is also real in the event that there's either an asymptomatic shedder and moving forward. So we agree that everybody should be tested and that only negative patients should proceed on to the procedure. Again, the CDC currently recommends routine surgical barrier protection for COVID-negative patients. We are agreeing with it, but depending upon availability and procedures, and particularly for people who are going to be anywhere near the airway, one may want to consider a more of a fitted protective mask. Again, we recommend that everybody all surgeons not be in the room during this particular time during intubation or extubation. So part of surgical care, however, is also postoperative rounding. And we firmly believe that everyone should assume the hospital is a contaminated area. Mask, frequent routine surgical masks, frequent hand washing and antisepsis and social distancing is center to everything. Face protection and gowns are required whenever really going into patient rooms, and particularly for people who are coughing. Assume that all the drainage fluids are contaminated and treated accordingly with barrier protection. The clinic telemedicine is feasible. It's oftentimes going apart, but depending upon the prevalence and availability, have a low threshold for viral outpatient testing. We may alter immune strategy for rejection treatment if a patient turns positive, even if asymptomatic. So assume until proven otherwise that the immunosuppression may alter the viral load, and that transplant patients with the novel coronavirus 2 may in fact have an increased amount of viral load and shedding. We do know that our immunosuppression certainly changes a lot of other viruses and their ability to replicate and to shed, and we would precaution until we know otherwise. The surgical staff and the people who deal with drains, wounds, and are in close proximity to people to treat them both as droplet and body secretion precautions. So the transplant conclusions, the final issue is there is much that remains unknown about our transplant recipients during this COVID-19 pandemic and the risk that it associates with the transplant healthcare worker. Asymptomatic infection is going to be a major consideration in locales that have a high penetrance of COVID-19. Finding ways to effectively deal with them in terms of protection and maintenance is going to be key. Urgent cases are going to be associated with an unavoidable degree of uncertainty. Testing availability and the significant rate with current tests of false negatives is problematic. And the personal protective equipment availability hopefully will go away, but it does put the transplant surgical staff, the surgeons, the fellows, and the PAs at considerable increased risk. And I think that we need to recognize and protect accordingly to what the known transmission rates of the disease are. And the perioperative care must factor in the impact of immunosuppression upon the viral containment and load. And it may or may not be important for viral exposure to healthcare workers, but we think that it should not be a neglected factor in the way that people think about the care of people with the disease. So with that, I'll say thank you and move to the next.
Thank you very much. And now we can move to our last presentation from Dr. Jonathan Hand from Ochsner Health, New Orleans, and who will still talk about how to protect the workforce, but more focusing on infection control. So thank you, Dr. Hand.
Thank you so much, and thanks so much for the organizers for the opportunity to participate here. So during the March 23rd American Society of Transplantation webinar, Dr. Marion Michaels really nicely laid out some basic infection control concepts and practices, and a lot of those have been laid out already in this webinar. But over the course of this past month, a lot has changed and around the world, and I think today I'm going to try to expand a little bit on that foundation. So we've really seen how far this pandemic has stretched our healthcare workers and healthcare providers. As of April 9th, I think earlier this week, the CDC came out and said in the US alone, at least 9,000 healthcare providers had tested positive for SARS-CoV-2, and at least 27 of these workers had died. And as most of us would probably assume, even the CDC admits, this is probably a significant underestimation. And when we think about the entire world and other countries, that number is substantially higher. So I do think when we're talking about protecting our workforce, we have to think of this as a continuum. We have to start in the community. And healthcare providers, we really need to be practicing what we are preaching. And this means when we're not in the hospital, we really need to be thoughtful, follow the social distancing practices. We need to wear some type of face covering in public areas, wash our hands routinely, especially in areas where there's significant community transmission. So we tell our patients this, but it's really what most public health organizations around the world are currently recommending. And we really need to follow our own guidance to stay healthy. And from the community, when you move into the hospital entrance, it's really important to discuss presenteeism. I think healthcare providers are traditionally not very good patients. We always want to be there to take care of our patients, no matter how poorly we feel or how sick we are. But I think this whole pandemic has really allowed us to understand this is not the time to come to work sick. If we do this, we definitely risk harm to our patients. We pose a significant threat to our colleagues who may not assume that we're ill. And though we want a sick healthcare provider to stay at home if they're not feeling well, we really need to make sure that we prioritize and we're streamlining mechanisms to test healthcare providers if they're not feeling well, particularly in settings where testing is limited. So I know everybody understands that we're all rethinking what routine care is and what routine research is. How frequently do we need to see patients? How often are we ordering certain labs and procedures? How can we optimize all of our virtual research meetings, virtual quality meetings, or listing meetings? I think we're all learning how to do that. We need to do better at that. And but at the same time, we need to be careful and thoughtful about that pendulum swinging too far away from in-person care. Because we really don't want that to limit care. We need to continue to do things that we normally do to closely monitor our transplant patients. But during this time, this will give us an opportunity to give more nuanced care. And I think we'll be able to think and come up with innovative ways to improve patient care that will benefit everyone moving forward. Also, in our facilities and our transplant units, it's really imperative to manage visitor access. I think we need to make sure that while visitors are in our institutions, that we're diligently directing them and directing the movement in certain areas. And I think if anybody who's been working in the hospital, I think everybody would say that this is probably one of the most difficult things for patients and their family members during this time, not being able to be with a loved one in the hospital and that sense of isolation while hospitalized. I know a lot of countries that have been hit hard by the pandemic have already implemented universal masking policies, but as of April 13th, the CDC actually issued a recommendation for all healthcare providers, all patients, and all visitors entering a healthcare facility to be wearing some type of face covering or mask, and also that they need to be screened for COVID-19 symptoms and fever. So we obviously want to reserve our masks, specific medical masks for our healthcare providers, but patients should be wearing some type of face covering when they're coming in as well, or visitors, excuse me. If we're going to be screening all of our healthcare providers, patients, and visitors when they enter the hospital and unit, I think a lot of times we do forget about our frontline folks who are triaging these visitors and patients. We really need to make sure that these frontline employees, like desk clerks, whoever else is doing this work, are protected, and that they have plans in place if there is an issue, someone who has a fever or someone has symptoms. You heard Dr. Benden earlier discuss candidate and recipient screening. And though there really aren't necessarily specific recommendations that we need to be screening everybody who comes in the door with a test, a lot of folks are screening patients, everybody who's being admitted to the hospital. And so if your center does have enough testing capacity to do this, and I know not everyone does in the world, I think, and another key part, it has to be done quickly. This may actually help help us with earlier isolation when patients test positive, and this may further limit spread to healthcare workers. Next slide, please. So as we move into the hospital setting or the unit setting, thinking about how the virus is spread, we understand that it spreads through respiratory droplets, close contact. We're seeing some data come out about other air and surface sampling that's been done and found contamination. And you can see in some of these papers, fans, toilets, sinks, doors, even the soles of some healthcare provider shoes. And one recent study from China suggested that contamination might be even more in the ICU setting. However, I think when we look at these studies that are identifying virus and RNA all around us in the air or in the environment, it's very important to understand if this virus is actually a competent virus that's existing at inoculums that are high enough to cause or transmit disease. I think we need and will continue to learn more about this. But while we are figuring that out, it's really important that not only is our hand hygiene diligent, but also our environmental hygiene. So we really need to make sure our teams are focused on cleaning and disinfecting areas, particularly those high contact surfaces. So all healthcare providers should be wearing some type of mask. Respirators are preferred, at least in N95, if those are available, and we've seen shortages around the country and the world. If those aren't readily available, then face masks, such as a surgical mask or procedural mask, is something we can wear. Also, we want to make sure that we are really reserving the respirators for any aerosolizing procedures. In addition to that, the mask, we want to make sure we have eye protection, gowns, and gloves. So negative pressure rooms are definitely ideal when they're available. And for us, and I think most folks, they really haven't been. It's hard to have a high availability of negative pressure rooms when you have over 300 patients that are positive in your hospital. But we really want to make sure we're reserving these negative pressure rooms, if we can, for aerosolizing procedures. Is anyone in the country or hospital caring for large volumes of patients with COVID-19? We all understand and we know the recommendations, but unfortunate reality is that our contingency and crisis capacity, we really don't have enough units. We don't have enough negative pressure. We have pretty significant PPE shortages of other supplies, and even our staffing. And because of this, we have to be thinking, and we've been thinking, but we need to continue to think drastically different about our resources and how we try to conserve those and use those wisely. I think most places around the world who are taking care of a lot of these patients are definitely extending the use of their PPE. They're reusing certain pieces of PPE. And some institutions have even been decontaminating N95s or other respirators. Some of them are using vaporous hydrogen peroxide, UV, germicidal irradiation, moist heat. There are others, but those are the ones that have been most reported and seem to be the most promising decontamination techniques. And I know a lot of these are being studied. However, the problem with these techniques is they may decontaminate masks differently by the type of mask or the model of mask. It can also be a pretty complex and difficult logistical process and workflow to actually get the mask from the provider, clean those, decontaminate those, and return them to the provider, because most of these techniques are intended for single user, and the same mask can't always be used for another healthcare provider. The other big piece of this is we really need to make sure that that mask or respirator that we've decontaminated keeps its integrity throughout the different decontamination cycles and processes. Again, this is all about protecting our employees and our frontline providers and everyone in the hospital taking care of these folks. And so I think we're all recognizing how to do this differently. And I know we'll continue to learn more as this pandemic unfolds. And with that, I think I'll pass it back to the moderator, Dr. Potena.
Thank you. Thank you very much to all of you for your very timely and very interesting presentation. So now we have some time for a Q&A sessions. I have some questions for you. And of course, I would encourage any of you, if there is any, to also raise some questions to the others, so we can have a very brief panel discussion. Just to start, I would ask to Chad regarding the organ procurement and the changes that he has seen in this period. So have you seen any change in the attitude of families regarding donation during the pandemic? So when you approach families asking the permission for organ retrieval, you see the same kind of attitude, or more refusal, more acceptance? Anything is changed?
Yeah, that's a really interesting question. We've been looking at our authorization rate throughout this thing, and it really haven't dipped. We would expect that families not being able to be allowed into the hospital to be with a loved one and approaching them over the phone for organ donation, we would see a dip in that authorization rate. However, we're not seeing that right now. We actually are seeing our authorization hold steady, which is really, interesting. We really expected to see that go down, but we have not experienced that here in New York City.
Yeah, because you see, I don't have a statistical analysis, and I don't know if that is significant, but looking at the numbers here in Italy, we are seeing more or less the same thing. So paradoxically, well, let's say unexpectedly, we have, of course, lower numbers, but the rate of donation, the rate of acceptance for the families has indeed increased in this period. Like a signal that there might be more solidarity and more sensitivity to the issue of donation in this tragic period.
Completely agree.
So I have a question for Christian regarding the screening for donors and recipients. So you mentioned as a screening for the donors also CT scan, and we know from different studies that CT scan may be more sensitive than PCR or swab when you have an asymptomatic patients. But you did not mention CT scan in transplant candidates. What do you think? So it's what are your thoughts? Would you also recommend, or would you do in your patients a CT scan for a recipient as well? Do you think it has any role?
Thank you very much for the question, Luciano. A very important one. We have discussed this issue also recently at the level of the ISHLT within our workforce, COVID workforce. And I think it somehow remains controversial. I mean, I am a chest physician by training, so I believe in the sensitivity of chest imaging, and I fully agree with you, but there are also issues about resources in some centers, and some centers reported that they're already stretched to the limit. But obviously, if we would all live in an ideal world, then we would have all our potential recipients and candidates screened and with various means, and that also would include CT chest imaging, because as I just mentioned to you, that case that has recently been published in the journal Heart Lung Transplantation, even though it was a potential donor, but there you are just on CT chest imaging, but picked up some changes that were compatible, I think, with the COVID-19, and that has actually prompted further investigations. And obviously, if you then are, practicing in an area with a pandemic status at the moment, then this is an issue and probably worth considering.
Yeah, although maybe I'm thinking for lung donors and people with trauma, maybe some kind of difficult to really differentiate the lesion in some cases, because the edema may be interstitial as well. So
that's correct.
And Christian, again, what do you think about the use of machine perfusion in this setting? So using machine perfusion, not only for lung, but also for other organs, do you think it may allow more time for testing and more time for ruling out the virus? Do you have any comment?
Well, that's a very difficult question. I'm not aware of a scenario in Switzerland where we have, or where centers have used that at this present time. And you always have to remember this is also an issue about shortages of staff. So you need, a team to run the machine, to get it conducted. And already, I think people are short-staffed and limited resources. I'm not really sure if centers would go down this route, but obviously, if in an ideal world, once again, if you have the chance to evaluate an organ more carefully and for a longer period of time, that would be ideal.
Okay, thank you. I have now a question for Dr. Pruett regarding the safety of the surgical team. As you pointed out clearly, it may be also that the surgical team can get infected, and then we have also to face the possibility that is the personnel that is transmitting the infection to the recipient during the surgery or shortly after. Do you think that it could be enforced a way to protect transplant surgeon for rounding or for making or doing procedures in COVID patient or suspect COVID patients in order to further protecting them and avoiding them they have any kind of asymptomatic disease, so kind of protecting them during the rest of the against the rest of the patients?
Yeah, I think we struggle with this a lot as to how to anybody who's symptomatic, we think should be cohorted out of other people's areas. That depending on the prevalence of the disease in your hospital, however, it's very hard to figure out how to do that. In Minnesota right now, we have very few COVID patients in the hospital. We have a separate hospital for which most of the admissions go. And our ability to look at people under investigation and to keep them cohorted away from the transplant people has been really difficult. And I'm very concerned that we've, put people at risk. Fortunately, as far as I know, we've not given anybody the disease. But the notion of patient-to-patient transmission, staff-to-patient, and patient-to-staff, all those things are very real and have been, unfortunately, very well described. Our concern with this is to keep everybody healthy. I'm very concerned. We don't have a lot of transplant people, and we think that we need to find ways to make sure our transplant staff remains virus-free. I think anytime they have shedding, either asymptomatic or symptomatic, is problematic. Certainly symptomatic people with fever and cough, they shouldn't be working, certainly with non-infected patients. But you can make the easy case that in areas of a high prevalence that everybody should be tested on a routine basis. But I just don't think we have the ability to do that at the present time. So it's a bit of a crapshoot in terms of how to both protect the healthcare worker as well as protect the patients from each other.
And do you, in your hospital, although I mean the prevalence is not that high, do you had personnel tested? So did your hospital perform a screening in all the healthcare providers?
No, we have only sufficient tests to test people who are being admitted for potential disease.
Okay, thank you. Now I have two questions for Dr. Hand. The first one is the same one. So you are from New Orleans, and to my knowledge, it's a different epidemiology of the COVID infection than Minnesota, as far as I understood. So do you have different attitudes? So also regarding the testing of the personnel. So do you have a lot of healthcare workers infected?
Yeah, that's a great question. I think we have had a lot of healthcare workers who have been infected, but I think it's really going to be difficult to tell whether that was a community transmission or not before all of the sort of stay-at-home orders were put in place and this universal masking in the community was put in place. So though we do have a significant amount of folks who tested positive, they were symptomatic. So we really have not been screening our healthcare workers if they're asymptomatic. So upon entry to the hospital, we're using symptom questionnaires and fever screens. But again, how good are those at actually picking up these pre-symptomatic or asymptomatic healthcare workers? I think that's the whole point, though, of having a universal masking policy for your healthcare providers and for your patients or visitors when they come in, so that you know, because we're not able to test everybody like we would like to do in a perfect world, I think that's one way that you're able to hopefully prevent that spread. I think as we've expanded our testing, we've been fortunate to be able to get a few different platforms up, and a few different types of media, making sure we have enough media. We've been able to get that. And so as we've expanded the testing, one of the challenges and struggles have been sort of operationalizing who do you screen. So, you know, anybody right now, currently, if you're admitted to our hospital or come in through the emergency room, not just transplant patients, but anyone, you are given a rapid screening test in that way. Also, some of our pregnant the people who are admitted for delivery or pregnant mothers are screened. And so we are capturing our transplant patients when they're admitted through the ER, directly admitted. But again, if you get a positive test, then what do? How often do you repeat that screen? You know, at what point are they, quote, cleared to be transplanted or, quote, cleared to have the procedure done? I think as we've expanded so rapidly with platforms, so rapidly with who we're testing, the big challenge and the struggle is really working through those workflows, because you can say, yeah, we want to test everyone. So what does that mean? And I guarantee you, we're finding every hour that there's a different possibility that you did not think of on, you know, who needed to be screened, who can come back to work. And I think though the societies like the CDC give some guidance on how to get people back to work and make sure we're screening people correctly, both in either a test-based or non-test-based or clinical strategy, it's really difficult to actually implement those, and in our model sort of changing by the day. And luckily, you have to be, I think, nimble to be able to get that type of large-scale screening done. But as you mentioned, given what's happening in our community and in our hospital, we think that it's imperative so we can protect patients and healthcare workers.
Yeah, this is very good point, but also the real challenge is how to move on after the let's say the stress of the emergency is past, because we will probably going to face a long period of time where COVID patients at a lesser extent are likely to come anyway. So we should probably envision ways to implement practices to enter the hospital that can last for a long time.
Yeah,
so,
I agree. Oh, sorry. No, I agree. I agree with the point. That's what these type of sustainable screening and cohorting and diagnostic strategies, they do need to be sustainable, because I mean, I hate to say it, but I think we all understand that we're in a new world now, and that this can't happen again in the near future, I think would be very naive to say.
I think we had a great discussion. I don't know if anyone wishes to ask anything else or any additional comment. So if not, let me thank you. And I also would like again to thank all the societies involved in this initiative. And I would also like to thank Emily Bloomberg for AST to leading this project and putting together the effort of multi-societies in organ transplantation. So thank you very much to you all, and have a great day.